I'm Ben Ryman, and this is Behavior Speak. In this conversation, Dr. Ruby Mannankara-Cabrera discusses her doctoral research journey focused on creating a culturally responsive curriculum for behavior analysts. She emphasizes the importance of cultural humility, sensitivity, and safety in clinical practice, and shares insights from her qualitative study involving behavior analysts. The discussion highlights the need for ongoing learning, building trust with families, and recognizing personal biases to enhance culturally responsive care.
I love it.
Welcome, Ruby.
Thank you for having me.
Awesome. Before we get started, I just want to acknowledge I am producing this podcast in the lands of the Comox, Clagus, Pomoko, and Tla'amin First Nations, and I'm grateful to be here. All right, Ruby, tell me a little bit about yourself.
So I am a board-certified behavior analyst. I've been a behavior analyst for 8 years, and I've been in the field going on 17 years now, various capacities for a good chunk of time. I'm originally from Chattanooga, Tennessee, but I currently live in San Antonio, Texas, and practice here. I've been working with children with autism for a really long time, but I also, along the way, have cultivated a love for teaching and mentorship, especially for the next generation. I'm a really firm believer in being able to pay it forward and to do good in that capacity. And so I've definitely built up the core values for myself of like integrity and compassion, and a lot of what I do is rooted in that. I'm also a heavy working mom, so I work as a clinical director, and I'm also an adjunct professor for Texas A&M San Antonio, as well as supporting some other universities as well. And I have 2 little ones. I have a 5-year-old and a 2-year-old, as well as a partner. So we stay busy with all the things, and so I'm really familiar with kind of being able to the equitable part of living life. What's up me a little bit in a nutshell as far as like where I'm at past experience-wise, where I'm at current life, and then who I am as a person.
And so, how did you end up getting into this field?
So I got into this field on accident. So way back in high school, we had a capstone project that we had to do. And at the time, I was really interested in neuroscience. My plan was to become a neurologist. I was really excited about that. And for this capstone project, we had to do something for the community, as well as develop some sort of way of giving back to the community and being involved. And so I ended up volunteering within a autism school. So at the time, it wasn't as prevalent of a diagnosis. And so there were many centers or schools set up to where they had children who didn't have a diagnosis blended with children who did have a diagnosis. And so I volunteered in that classroom for a summer and decided to build up my capstone project around that. I was there for about 7 to 8 months in doing that during my senior year of high school. And I learned about applied behavior analysis because one of the members of the board that was there was a board certified behavior analyst. Never heard of it before, didn't know what was going on, but was learning how to apply behavior analytic principles. And so I decided at that point, I'm going to be a neurologist who works with children with autism. So that's how I started framing that around. And then come senior year, I had originally committed to Emory to do neuroscience. And during that time, I was like, well, I'm not sure if this is what I really want to do. And this is how I want to work with the autistic population. And that led to me applying to a couple more schools. And then I ended up deciding to go to Wake Forest University instead. And there I continued volunteering and working with children with autism. And during that time, I actually ended up double majoring in psychology and religion for having the opportunity of learning applied psychology, but also the connection that we have as people. And so it's probably odd, like having a second major of religion. But one of the things I loved about the program there was that it wasn't heavily focused on the construct of religion as most people in our society think about it, but it was in the sense of like how communities come together and create lives and build their behaviors around one another, which has created a lot of things that we do within society. And so that led into me looking into other options of like, you know what, I don't think neuroscience and becoming a neurologist is on my path. And I really enjoy working on this population. So I ended up applying to master's programs for ABA and ended up in Boston at Northeastern. And that's where my journey really heavily began. Completely on accident, but in a very interesting way where I was trying to make the framework of fitting being able to work with children or adults and so on with autism in the medical sense, but I ended up doing it in a completely different way. And I don't regret it because I've really enjoyed where it's taken me, what I've learned, and then what I've been able to help give back as well to the field, and then also for those mentorship and teaching for the next gen.
Right on. So were you doing any sort of ABA kind of work before you started doing the master's degree, or did you just kind of go right into the master's degree and then kind of start doing work?
So during my undergraduate time, I ended up volunteering at an ABA. It was an ABA center in some capacity. So we had children with autism that were there, but it was replicated a school setting. So getting them used to what the school expectations were and learner readiness skills. So during that time, I volunteered and learned basic principles of ABA, how we utilize it, that framework of supporting them and being a shadow and learning skills. And so we're teaching them directly, but then having opportunities where they're generalizing those skills in that replicated classroom setting. And so I had that chance to do that before going into my master's degree, which was really helpful because I also got a chance to see what the perception and stereotypes were for those who are diagnosed with autism. And sometimes that created a barrier for, even families or caregivers to fully divulge into what support is going to look like, and that the journey is going to look a little bit different, but it's an exciting journey overall. And so being able to learn that.
So what were some of those perceptions and stereotypes?
So some of the things that we ran into, so this was in the South, so in North Carolina. So a lot of families that I was able to connect with during that time would share like, oh, I think this is a result of something that his dad did in the past. And so this is karma coming back to us. And so it's a very deeply rooted assumption of this diagnosis is because of a mistake I did. That was something that was pretty common. I saw it in various ways with different families and caregivers. There was also the perception of this is just a temporary diagnosis and it's something that can be cured and we can overcome it if we throw everything at them all at once. And so it was a combination of therapy, utilizing different psychometrics, and then also the medications. And so it was interesting to see this, like, let's cure it and let's cure it fast and then move on with life, which is really hard when you're directly working with the population and supporting them, because their journey is a journey no matter what, and being able to change up the environment rather than changing the person themselves.
So once you got your master's degree, then what'd you do?
So after I got my master's degree, I actually went into nonprofit work as a behavior analyst. So I worked alongside social workers in the greater Boston area. Cool. And we were actually working with individuals who were diagnosed with ASD, but other diagnoses. So they had several comorbidities, such as depression, anxiety, oppositional defiance disorder.
Do you have a credential with the International Behavior Analysis Organization, the Qualified Applied Behavior Analysis Credentialing Board, the Behavior Analyst Certification Board, or would like a certificate of attendance for another organization? You can earn 1.5 continuing education units by going to www.behaviorspeak.com, click on CEUs, and enter the 3 secret words. The first secret word is Hindu.
And that was a really good experience for me because I was able to support them in how we're looking at the behavior aspect. and they were able to look at the different psychoanalysis aspects of things. So being able to collaborate in that type of environment. And during this time too, it was since it was nonprofit, we did a lot of Medicaid, Medicare support for these individuals. And so being able to be a part of their lives, there's a lot of in-home work. We're right there with the families in supporting them and what they needed. And so during that time, I did very, very heavy, more so like behavior management approach. So it's not necessarily like skill acquisition that we're teaching brand new skills. It was being able to teach them appropriate replacement behaviors that help them navigate their environment a little bit more fluidly for their families, for themselves, and then helping to facilitate independence. And so I really enjoyed that experience because it got me to step outside of my comfort zone a little bit, in the sense of I had done a lot of my fieldwork hours in a clinical setting and an in-home setting, but not in the framework of nonprofit and what that looked like. And so you're very much in with the family, their lifestyle. You're trying to make things really connect with what they're doing, because if you do something that's more of that medical model, isn't quite congruent with them. And so it was really hard in that sense of, hey, I would like to do this, and families coming to you and saying that doesn't really work for us, and nor does that make sense for our everyday life. Like, I have to consider that I work 3 jobs. This is what's reasonable for us to do in supporting my family and also supporting my child. And I want this help, but we need something that's a little bit more realistic into what is culturally appropriate for us as well. And so looking at those aspects during that time. So I spent some time there, and then soon after moved to Austin, Texas, and then went back to the clinical setting. And that was more of the traditional medical model, clinical support, and so on. And did that for a few years, and then went into telehealth, supporting Medicaid kiddos and their families out in New Mexico. And that was a really enjoyable experience, actually, because one of the things that we had to divulge in was the fact that we were telehealth, and I actually went telehealth before COVID happened, framing treatments or like interventions and such virtually, and how to show that and making it make sense in their homes. And since we're telehealth, we're right there in their home, seeing what their daily routines are like, what their cultural expectations are like. And during this experience, what I found was I had to really dive into the family as far as like, what are your expectations for your child in the home? How can I help like frame this in a way that is going to make sense for you all and that you can practice it? And that's where, as a clinician, I started to recognize that this piece of like cultural responsiveness wasn't directly taught to me, but it was cultivated from my experience thus far. And so presenting that to families in a way where, like, I want to be able to provide you with ABA therapy, but I want this therapy to be culturally sensitive and incorporate a lot of what you value as a family. And so that definitely kind of led the way to where things have gone for me in my career. And I'm actually now back in the clinical-based setting as well. And I'm appreciative of it now, especially like being in the San Antonio, Texas area. There's a lot of cultural, ethnic, linguistic diversity, as well as SES diversity. And so being able to actively practice that as a clinician and modeling for other clinicians, how do we do that within a medical model, which can be really tricky.
Okay. Well, we're going to dig into your doctoral journey and a lot of that piece in a sec. This gig you had in the nonprofit sounds really cool. I'm curious sort of how that experience, because you talked about sort of how the medical model maybe just didn't work as well when you're sort of in people's homes, and you had some of that experience too doing the telehealth. I'm curious how that has sort of affected or even sort of changed maybe the way you do the clinical work now in the clinic setting.
It has changed it vastly for me. I think when you're like back then, I did a lot of graduate work with learning the medical model and what that looks like. But I do remember having a moment with my mentor, and she's one of the most respected people that I have that's part of my journey on becoming a behavior analyst, and also kind of being able to fast forward and helping to influence kind of my doctoral journey was I remember having a conversation with her. We were working with a family, and I had asked her, and this is a very young graduate student, me still learning all things ABA, and also the current practices at that time. I asked her, I was like, well, why aren't we, incorporating this kiddo's abuela into treatment? And the fact that this family utilizes a very machismo perspective on things, meaning they really value little boys in their family and making sure that like everything is taken care of for them. They are supported. They don't have to lift a finger and that aspect of things. But we also need to provide services at that time too. But we need to make it make sense because we're directly working with mom and dad, but also abuela, who is very much like, hey, we're gonna do everything we can so this child does not have to lift a finger. So I had asked her openly about this. I remember at the time, she answered this in the best way possible because during that time, this was, before the heavy emphasis of compassionate care and so on, she had shared, we stay true to our practice as behavior analysts and behavior analytic principles. And so we provide as much information as we can, but sometimes some of the things may not always work when we try to culturally adapt it in a way that's productive for the family. And I recognize like her answer was the best that she could give me at that time, but it wasn't enough. And I think she recognized also that it wasn't enough and there was still more work to do, but it was something that stuck with me because that's where, after I got my certification, I decided to go nonprofit to get more of a glimpse of what that looks like and what can be done. And so in this time, because I've really appreciated the opportunities that I have had with working in different settings and different families, different demographics, which has been amazing. Now as a clinician, I am hyper aware of when we're presenting, when we're even presenting assessment results in the medical model, because we have to do our initial assessment before we even start services. When I'm presenting it now, I'm very, very aware of how the family is responding, the types of questions that they're asking, the types of questions they're not asking. So like what their body language looks like, and then also who is speaking. And then I will also ask them, and many times in conversations when we start, how best do you understand information? Whether that is being able to talk through each portion of it, or is it, do I need to have somebody available that can appropriately translate things to you to be comfortable with?
Sure.
And so like those are just small steps in being able to incorporate that. I've also learned that sometimes when we write goals or we have these preconceived ideas of like, we want to work on this and we want to work on that, and we jump into creating our treatment plans, a lot of times we may not always get the family's input before we get too deep into the writing process. And so creating that ongoing dialogue by asking them clarifying questions or admitting when we don't know something. That's something that I have heavily practiced, is when families mention anything in their initial interview for services, or even when they're just coming to just get things started, I'll ask them, what does autism look like for you in your community? And it's a very broad question, but it helps to facilitate how are we going to actually approach this in a way that is supportive for the family, because we don't know how long that journey is, but we know we're going to be a part of it at some point. So let's meet them where they're at. So I would say that taking all of these experiences, especially that nonprofit one that I had, it has changed my approach in how I connect with families and collaborate with them. Instead of one of the things I learned even in this past 5 years or so is I used to have the viewpoint, because for a long time our field incorporated this into practice, so that we're the expert, we're the ones who know the field.
Sure.
We're the ones that should be telling and conveying this to the family. But now, in these last 5 years or so, I've actually changed my approach to, I'm walking beside you. I'm not trying to get ahead of you. I want to make sure that we're meeting each other where we're at. And if there's something that you don't quite understand, or something that isn't appropriate for us to work on, that is not approachable for the family, then we're slowing down and we're reassessing what's appropriate there. There are times where we might have to, lead a little bit, and as the clinician and sharing, hey, these are some of the things that might come up for your child, or these are some of the things that might come up for your young adult. And these are the steps that we can take. But then opening it up to the family of what is going to fit your lifestyle, what is going to fit your values, and what is going to fit your cultural practices as a family, because that's going to be the most meaningful for them. So there are times where, more often than not, I'm with families and standing with them and walking through the journey side by side, rather than going too far ahead of them to the point where it makes it really hard for a lot of families to keep up with what we're hoping to do.
Yeah, no, I love that. Okay, so what made you decide to go back to school again and go for your doctorate?
Well, I originally wanted to go right away. And at the time, my husband was like, well, how about you work in the field, get some experience, see what it's like. And so that's where all of this kind of mapped out for me. And then what I learned along the way was I found a big passion and drive for helping families who just did not understand the amazing things that behavior analysis can do. A lot of it due to other factors, right? Like there's ethnic and cultural diversity and then practices that don't necessarily have a word for for the diagnosis of autism. And it's more recent for many cultures or many countries too. Or even being able to support families when it comes to how do they navigate like that path. And what I found was, as I started taking on trainees and apprentices, that was something that was coming up pretty often, because, we teach the assessments and we love our broad assessments of the VB map and the ABLES, which are great. But then I would get questions of, well, what if the family doesn't do these things? Or what if they don't want to do these things because it's not part of their cultural practices? And that's where it was a recognition of like, well, at that point, we need to work with the family and we need to figure out how to best help support them, because the assessment is not going to tell us everything that they need in order to support and be with their child for the next 10, 15, 50 years. And so that was when, around that time, and I also realized there wasn't a lot of behavior analysts talking about cultural responsiveness and how valuable it is within our field and how it needs to be incorporated every step of the way. And it's not just a majority minority perspective, but it's all of us. All of us have our own cultural practices, the values that we have in the way that we do things. And it's so idiosyncratic across everyone that it can't be ignored. And that's what builds culture. Like Skinner talks about this, right? Like all the values, the practices that we have, that's what builds culture for people to create the behaviors that they have. And so then it dawned on me, well, Ruby, I think you need to go back to school. So that's what I went in with, because the couple years leading up to the time that I decided to go into doing my doctorate, I realized that there needed to be more of being able to do that. And then also, I'm a person of color, and I didn't see very many people of color who were becoming behavior analysts at the time. So helping to support that piece of, okay, let's dive into this topic, which is a really hard topic. And I learned that too during my doctoral journey. And then also being a person of color who's also doing this as well. I'm also a child of immigrants, and my parents are blue collar. So they worked really, really hard to help support like my family and such. And I was the first to go to college. And so it was like, well, you know what, we're gonna take the step of talking about this really hard topic in this amazing field that has a lot of solidarity in its principles and its practices, and we're gonna do it with this life history that I have too. So that's what led me to jump into doing my doctorate degree. And one of the things that I did differently was I had to think about if I wanted to go solely into doing my doctorate degree in behavior analysis or something broad. Many years ago, I had talked to my mentor about this, because she was aware that I was interested in doing my doctorate degree, and she had shared with me the essentially the path of going into a doctorate that does exclusively behavior analysis and something that isn't, and like is more broad, and the pros and cons of that. And I remember that conversation being a little intimidating for me because it was, well, do I need to do that and go into behavior analysis or do something else? And that's where I took that time of, I'm going to be in the field, I'm going to practice, I'm going to decide when I'm ready. And that time was, came up, and I looked at everything. I looked at what I was doing and how I was training, teaching, mentoring others to become behavior analysts. And I realized that it's more of an organizational piece of it. And so I had to kind of look into different programs, because doing a doctorate degree in behavior analysis is very, very niche, and you have that piece of it, which is amazing. But also looking at the greater systems that create the opportunities for behavior analysts to be well-rounded, which at that point, looking at the way our BACB is created in the United States, you're also looking at graduate programs and like that structure and how we're educating students who are then becoming practitioners. We're looking at current practitioners and their training and support models and how they're putting out clinicians into the world. And so that's when I looked at, it's more of, we need to look at the organizational structure of things. And so I decided to apply to Doctorate of Education programs in organizational change and leadership instead, because of that aspect of, it's more of the piece of changing the system in which we're cultivating practitioners to help facilitate an environment and practitioners who are able to do culturally responsive care, heavy compassionate care, patient-centered care, and what does that actually look like? And so that's kind of what led me to doing an EDD versus a PhD with an emphasis in behavior analysis. So there's not very many EDD individuals out there, I've come to discover, but I am really thankful for the education that Baylor gave me during that time, because we did heavy leadership development and what that looks like. And what many clinicians don't realize is that they have to do a lot of leadership qualities to practicing,
for sure.
but also the organizational change piece. What does it mean to restructure, but restructure in a way that is productive, consistent, and fluid over time?
Super cool. So I want to know a little more about the program, because I do. I mean, I'm biased, and I don't have a doctorate, but I do often wonder, and maybe folks that have them can tell me why folks get PhDs in ABA if they're not going to be professors. I understand professors getting them, that makes sense. You're going to teach a behavior analysis program. It probably makes sense to have a doctorate in behavior analysis. But I often feel like folks are missing out on a great opportunity when if they're clinicians, especially because I think there's a lot missing from our graduate programs. They're certainly in terms of all the things you mentioned, but also things like just counseling and therapeutic skills, and all the things that we need to sort of work with folks. It isn't necessarily taught in a lot of these programs. And so I'm curious, what was some of the coursework? What were kind of some of the courses you were taking, and sort of a little more on kind of organizational change and leadership, and just for other folks listening, because I think there's a lot of folks that are thinking about doctorates and feeling like they just have to go master's, PhD, and go.
And it's a journey. I'm going to base off my experience, but I really think that it's valuable to take your time in looking at all the options, because as you said, it's really easy to just go down the path of go master's, PhD, and so on. But it's a matter of what you want to do with it afterwards. So for me, I actually really wanted to have a foot in clinical and a foot in university, because I saw this area of, I want to be able to make a change in the clinical aspect of applied practice, but also be able to cultivate these conversations in the classroom first before clinicians are out there in the world.
Yeah, very good.
And so that was part of a big reason too that I ended up going down the path I did. And so in my particular coursework at Baylor, doing an we did we did the research aspect of things. So I did research methods, qualitative, quantitative research, so all of those fun things with helping with actual research during that time. But we also did leadership policies and principles. We did public policy and what that looks like. We also looked at systematic changes. And so these were all classes that helped to facilitate and teach skills that we needed in order to create organizational change, but then getting down to the root of like, how do you make teams function? How do you make and support the different tiers of leadership and creating that under principles and those aspects of what you value. And so I did coursework in that, and then even things like an instructional design. So instructional design is something that's pretty common in the education field, but it's applicable when it comes to organizational structure, because there's a lot of teaching and training that's done within organizations, whether they're public or private. And so if you're able to create material, understand the purpose of it, and then facilitate it in a way that aligns with your organizational's purpose, you are able to create like strong instructional design and follow through of the core principles or values that you're putting into your employees or your staff. And so my coursework heavily emphasized that. We also took a course with psychology as well, and learning about adult learning. So as you kind of move up within your career, you start to find time and time again, you're working with adults. And for us as behavior analysts, the majority of us work with the early intervention or like adolescent population. But when you're looking on the things from this side, you're working with adults and adult learning, which is andragogy. And so in that aspect, during my coursework, we had to learn how adults learn and how do we tailor things to help adults learn new skills. Many of us as adults are already set in our ways on how we learn, how we study, how do we motivate ourselves. And so when you're asking for organizations to put in a new initiative or to try a different aspect, so even a couple years ago when the ethics code updated to incorporate cultural responsiveness, it was like, this is great, but how? And then how do you to adults, that's where that comes in. And so being able to incorporate that piece of it as well. So within my doctoral work, I got a chance to have this opportunity of looking at all those different aspects. We ended up diving into different departments as well. So within educational psychology, the education department, and then also within our like mathematics, because we're looking at qualitative research as well.
Okay, wow. Yes.
And it helped to really give me a well-rounded approach in what I wanted to utilize my doctoral degree for, especially since I'm going into this niche of, well, I want to help support the growth of this next generation of behavior analysts, but I have to do it in a way, and I have to have others kind of support it in a way that is not just an individual approach, but something that is system-wide, and then we're applying that change overall. So that was, I'm really appreciative for Baylor's program and the skills that they were able to give me during that time.
Really cool.
Especially since I had a cohort or my doctoral cohort. We all came from different fields. So
I was wondering,
it was great to be able to talk through how we're applying these aspects, but in a way that is meaningful for each of us to make systematic change.
Neat. And were you kind of moving towards your dissertation here? Did you go into this program knowing you were going to work on kind of cultural responsiveness and behavior analysis, or did that something that came later?
So it was something I went in with it. So during my doctoral interview, I actually talked about like what my proposed dissertation idea or topic would be.
Wow.
And it was this. Mind you, what I ended up producing as far as my dissertation is a really small piece of it, my original idea. I got feedback early on when I first started the doctoral program from my faculty advisor that my topic was great, what I wanted to do was great, but it's probably like 20 years of research that I need to do to get to what I wanted to achieve. But being able to at least like start a snippet of it. And so that was something that I went in really, really passionate, really excited about this. I'm still really excited about this. And so it's something that I went into the program knowing that this is where I wanted to really help fill the gap in applied practice and in research and supporting our next generation of clinicians.
And what was that big lofty goal?
Oh, goodness. So my original goal was to actually create a culturally responsive curriculum framed within behavior analytic principles that could create a train the trainer model for behavior analysts that are practicing within the field. And so I'm heavily familiar with the clinic-based setting or the medical model, being able to frame it within the medical model, because I was aware that doctors, social workers, nurses, they all have courses, they all have training programs that help them learn about culture responsive care or cultural humility, but we don't have one yet.
No.
And so that was my big lofty goal that I went in with. And I learned throughout my research journey and such that there's a lot of pieces that we need to pull together in order to create something that is also socially valid and reliable in training culture responsive care, because cultural responsiveness and inclusion is something that doesn't start outwardly. It starts inwardly as the clinician. You have to recognize your own pieces of cultural values, your cultural identity, what you do, and then also self-reflection. So teaching clinicians how to do that first, and then beginning, okay, how do we take that? Because we're always part of the conversation when it comes to treatment. So that was something that I learned along the way, and why my faculty advisor suggested this might be, a few years of research and development, but it's not impossible.
And is that still something you're thinking about?
It is. I think with two little ones, sometimes, we have our moments, but it is something that I still want to help support and help drive as well, because it's something that's very close to me and what I've seen. And I think also part of my own journey as a clinician, there have been moments where I've had to learn, you know what, I really don't know what I don't know, and I need to ask, but I also need to recognize, what are my biases that are holding me back from fully supporting, this child, or fully supporting this family. And that's something that even for me, I recognize that in myself, but sometimes encouraging other clinicians to begin that process can be really, really hard, because we want to be right. We want to be the one who's the one that's guiding the way for each family, and the one that parents look up to and so on. We don't necessarily always want to be wrong, but in being able to recognize that, hey, I don't know everything and I need your help. You're the expert on you. And I need to be the expert on myself as well.
Okay, so what did you decide to do? What was your topic?
So I ended up doing a multiple case study on current culture responsive practices with behavior analysts. So my study is a qualitative study, and a little bit different from our single case research that we have in our field. And it's not a quantitative study either. So I will admit that when I was advised to do a qualitative study, the behavior analyst in me was like, oh, I can't do that. I need a qualitative study. No one will take me seriously. But I learned along the way that we actually need this type of research too, to enhance what we do, whether it's in a lab or something that is the single case study design as well. And so my study ended up looking at what are those current, how do behavior analysts practice culture responsive care. And one of the things that I did was I pulled my theoretical framework, which was something that guided me throughout my research and dissertation, from translational nursing, actually. So I used the ACCESS model, and the ACCESS model is actually an acronym for a specific approach for cultural humility and inclusion practices in transcultural nursing. And it stands for assessment, communication, cultural negotiation and compromise, establishing respect and rapport, sensitivity, and safety. So my main research question looked at how are behavior analysts right now doing culture responsive care within this ACCESS model. And then I had 2 additional research questions just because I was curious to see along the way as I was gathering this information. The first one was the specific strategies that behavior analysts were using for creating culture responsive treatment and then their approach to care as well. And then the other one, because this was something that, as I shared earlier, it started to come up more and more, like in the various experiences I had, especially within that medical model. The second question that I had to ask was, what are the perceived barriers that were making it difficult to provide culture responsive care as well? So that's what my dissertation ended up focusing on was my primary research question, and then I had these 2 secondary questions.
Right on. And can you tell me a little bit about, well, first question, so you're using this access kind of framework. Now, obviously I presume these behavior analysts didn't know about this framework. So you were just sort of assessing what they were doing and see and kind of how it fit into that framework?
Mm-hmm. So within my study, I actually I ended up having 4 participants, and they were a mix of BCBAs and BCBADs from across the country. And one of the things that I had as part of my participant requirement was that they had to be practicing for at least 3 years post-certification and in a home, school, clinic-based setting or telehealth, and currently providing ABA therapy. And within that time, I also noted in there that I want to have a very robust way of data collection. So what I ended up doing was I had an individual interview with each person discussing questions that were framed around this Access nursing translational model. And then I had a focus group and pulling all of them together to discuss these questions together. And then the last piece I had was I actually had them write written reflections each week based off of one of the components of the Access model. What I found was it was really helpful to share each component of the Access model and what it was, and then letting them share how they viewed it and how they were practicing it at that time. And that's how I was able to gather quite a bit of information with that and framing it in each component of the Access models. One of the things I love about this model is it's an acronym, but it breaks down things really nicely because assessment is something that we do, and we do it from the start of services, throughout services, and even as we're troubleshooting things too. And the next was communication. We're constantly talking to our caregivers, our families who we're working with, and so how are we communicating with them? And then the other piece of cultural negotiation and compromise. Here we're starting to open up more of asking those clarifying questions, being able to approach families and saying, okay, what do you do? How do you practice this? How do you view this? And opening up that opportunity for understanding between both parties. Then establishing rapport and respect. So we hear this a lot in our field of pair, you build rapport. And so how are they actually creating respect between themselves and their families and the caregivers, but then also building that rapport along the way? And then the last 2 pieces, how are they being culturally sensitive to what they're sharing? And then creating cultural safety was another aspect. And so each one of these areas during the individual interviews, I was able to dive in more deeply of how each practitioner was viewing these and how they were practicing them. And then also kind of assessing to see, as they were doing this constantly with their families and such, what they recognize within themselves as well. And so some areas of talking about this I learned during that time can be tough because you also have to recognize biases that you might have and what that looks like in conversation. And when you're trying to build that rapport and establish respect, it can be really hard to establish respect with a family that you want to help if you have a bias that's actually giving you a roadblock. Don't identify that bias and recognize either I need to reconcile with this and be willing to learn from this family, or I need to step away from working with this family because this bias is not letting me be a completely ethically practicing clinician. And so that was something that I got a chance to really dive into. What I found with the written reflections, because after we had conducted our interviews and then our focus group together, the clinicians shared a lot of their opportunity of after they've gotten time to process, after they're recognizing what they do within their practice, the written reflections yielded more information about what their perceptions were of each one of these areas. And that's something that I want to say, based off of my study and what I observed, doesn't happen very often, where we're taking a step back and reflecting on what those interactions look like. How did we navigate those? Did we recognize when we may have needed to stop making suggestions and listen to the family fully to understand what their preferred practices are?
Yeah.
So I really did dive into quite a bit of data collection in different topographies or in different ways to gather that information to completely understand what does cultural responsiveness look like. There's not a lot of information given to us on the ethics code. And so this was where, like, hey, let's do a deep dive, but we're going to do it in different ways. So that's how I ended up gathering quite a bit of data and relating it back to this axis model with each of my participants.
Now, you just had 4 folks. First off, how'd you pick the 4?
So this was tricky. I actually ended up getting some help with gathering participants for this study, and I got a lot of interest, which is great. And I knew several people were super excited about cultural responsiveness and diversity and everything. And it's a fun topic. It's also a hard topic too, and many people were willing to learn. From there, though, I had to also narrow down how long they had been practicing, if they were currently practicing, if they were in the United States, if they were working with either early intervention, adolescent, young adult, or adult populations. And so, and then also who could commit to the time commitment, because it was about 3.5, 4 months of being conducted. It also required independent tasks. So those the writing reflections that they had to do.
Yeah.
And participation in an extended interview, and then a focus group of other participants as well. So if they were able to meet all of those areas of criteria, then they were included in the study.
And so all 4 of these folks were, well, first off, was it why 4 versus 40? Or, I mean, obviously the time, but as one big piece. But
so in qualitative research, it's really heavily focused on the experiences that are being reported to you from your subjects. And when you have a large amount, it can be really difficult to gather the complexity of it. And I also didn't have that much time to be able to have, 10, 15 people and such. And so within qualitative studies too, you're able to find those connections and the common themes that arose from that. And so having a smaller participant group was helpful in making those connections. And when I actually had to go through the data analysis process, it was analyzing the data from their entire interviews, as well as their responses when they were with the focus group with one another, and also each one of their written reflections. And so you have a pretty robust amount of data when it comes to that. And so qualitative research typically has, or I'll make a broad statement here, but typically has like a small amount of subjects within it, especially since I did a multiple case study, and the multiple case study is each one of the participants were its own case within my global study itself. So that's why I had a small number of participants for this.
The second secret word is leader.
And so these, lots of questions about the 4. These 4, because it's all about them. These 4 came in, I presume they all believed that they engaged in kind of culturally responsive care?
So one of the questions that I had in my participation selection was, one, had they learned about cultural awareness, diversity, humility, all of those things during coursework? Or if they learned it on the job, or they learned it on their own. So each one of these participants actually responded differently. So some had experience during their coursework, some had none during their coursework, some learned it on their own, some learned it when they were with an organization who was practicing it. And so many of them had some experience, but not fully comfortable with what cultural responsiveness is. And I also had a follow-up question that I ended up asking the participants of, have you taken any additional like CEs or training on cultural
Sure.
responsiveness? And they all shared that they had, but it was more so talking about what cultural responsiveness within our ethical practice as behavior analysts.
Okay, and so I really liked. I was listening. I was reading through. It's a long one. But I was reading through, some of the text and some of the sort of the thoughts and the ideas folks had. I was really drawn to the first participant, Allison. I think she'd seemed like maybe she'd been in the field the longest, and I also noticed she was in Washington. There seems to be a little, this is a bias for me because I'm in British Columbia, but there seems to be a lot of work around cultural humility and quality of life and things happening in Washington. So I'm not sort of surprised. And I know of a few practitioners over there that are doing some really kind of good work in that area. And so right away, something that I got out of it was just, for anyone that maybe wants to maybe reach out to you and get a copy, you just get really some ideas on sort of how to talk to families in a different way and how to approach things. I'm curious sort of what the focus groups were like when they all kind of came together, having all those different perspectives.
So the focus group was actually really enlightening to watch the dynamic, because there were areas where many of them were able to share their vulnerabilities as clinicians with one another. And a couple of the participants also shared that, there are times where they sometimes don't want to admit when they're wrong, or they don't want to incorporate as much. And it provided an opportunity where they could share that piece of it. And within the focus group too, what was interesting was many of them had similar strategies in how they're approaching, what we would call culturally responsive care. So how are they communicating with the families? How are they building respect? Or how are they maintaining the rapport that they already have with them when they need to ask about something that's a little bit more sensitive? Every single one had a different way of approaching it. So for one of my participants, because she has the opportunity of being bilingual, she would assess and see with the family directly because she had that perspective or that privilege of being able to do that. Versus another participant who shared, I wish I had more ability in my linguistic capacity, but I've had to learn I need to reframe sometimes how I speak or talk about things. And that can be really hard for me when I have a limited amount of. Yeah. And so it was interesting to see that dynamic of there's a lot of similar approaches, but the actual practice of the approach or the implementation of the approach was done slightly differently to have the same end goal in if it was to build rapport or if it was to create some sort of cultural safety for the family to divulge more information. And so that was something that I really appreciated, because we sometimes like to blanket things and say, okay, well, if you try and talk with the family, like, yes, we can talk with the family, but how? What will that look like? How are you approaching the family who's directly in front of you and not using that same approach to all 5 families that you work with? And so that's where we start to tailor and individualize our approach in practicing some of these areas that are outlined in that access model.
I want to get into sort of some of your kind of results, I guess, and outcomes. But before we do, I had a question about a couple of the terms. I've had a lot of conversations about cultural topics on the podcast, and through it, there's been a lot of different terms that seem to start with the word culture or culturally, and there's a couple of in here that I haven't seen all that often, and maybe in part it's because you took the model from a different field. But what did you mean? What do you mean in the framework for cultural sensitivity and then cultural safety? Because these are terms that we don't hear a lot as much.
So with cultural sensitivity, so this is something where it's similar to cultural safety, but what we're trying to do here is we're trying to deliver a diverse, culturally sensitive care or cultural diversity of groups. So for example, there might be certain terms or certain ways of how you talk about something that needs to be culturally sensitive to the family that's directly in front of you. So for example, there might be, like, I know, like within my family, when we're talking about, I grew up very heavily Christian and Protestant and such as well. And so when people would approach talking with my family and such, many times because they see our face and there's the stereotype and so on, they would assume that we would practice Hinduism and such.
Sure.
And so they would frame things. And growing up in Tennessee, you know, that where everyone is learning how to communicate to a brown family. And so when they would approach us, they would say like, "Oh, you pray to an elephant god, right?" And so, and it's so innocent. And that's the thing, is that a lot of times it's more so the stereotype, and then you end up divulging into that stereotype.
Yep.
And for my parents, it was like, well, no, not quite. And then they would have to share and divulge, like, well, we don't practice Hinduism. We're practicing Christians, and so we pray to God, and being able to explain that. And that's where, you know, you're changing up your language, right? So you're changing up the way that you're speaking about it. And so, or if you have a family who shares that they're deeply spiritual, but they're not necessarily within the general construct of the religious practices or the global practices that we have, right? And then how are we talking about that with them? So if we're kind of relating it back to, let's say we're trying to teach adaptive skills for the child, and one of the things that they would like their child to be able to do is practice meditation, because that's part of their spiritual journey and what they do as a family.
Right.
We might change the way that we speak on it, and so not accidentally say and overgeneralize, you know, when you pray, because that's not changing the way that we're talking about it and referencing it to fit the family to be culturally sensitive in that way.
That's
so
difficult.
We're not looking at it in that perspective, because cultural sensitivity, sometimes when you first hear it, you're like, oh, I need to omit things.
Yes.
It's not necessarily that. We need to change our framework and how we're approaching the language, or even our body language, and what we're doing to help fit the family's framework. And so that's where that cultural sensitivity piece comes in. And then with cultural safety, this is where you're enabling the patients or clients to derive a sense of safety, of sharing what their practices are. They feel comfortable to share with you what exactly their values are, why their values are the way they are, and why they're created that way. And they can open up that conversation of, this is why we would like, you know, our young adult to learn how to do this, because this is something that we believe in and we think that is part of our daily life. And so when you create a sense of cultural safety, sometimes this can also be created using a couple of the areas of the access model together. So when you've established respect and rapport, you can in turn also create cultural safety when you are able to have that cultural negotiation and understanding, meaning you can express and understand the way that you approach this within my own practice, but you need to can you tell me more about how you actually do it? And that in turn, creating that communication helps to create a sense of cultural safety, where the family can convey to more and more the information that is going to be helpful for how they can practice. So for example, if we create an intervention that kind of completely goes against the family's like perspective on things and such, that can create an opportunity where cultural safety is not achieved. So kind of looking at popular parenting styles right now. So we have traditional parenting styles that many boomers or even some like early millennials or like Gen X are doing, versus gentle parenting. And so if we are creating a platform where we can talk about the different parenting styles and gather more information, that's that opportunity to create that cultural negotiation, that collaboration piece, so that we can facilitate cultural safety in how we might be approaching a parenting style. And so that's something that the cultural safety piece sometimes is a side effect of utilizing all of the aspects of the access model together. And it helps to facilitate that piece of, I am able and I am comfortable implementing the treatment that you've created for my child or my adolescent. And, you know, we're able to continuously have that collaboration because it helps to support our family, and I feel safe with you as the provider.
And so how do you know that things are culturally safe? I assume that's something that's decided by the family. Is that just based on them being willing to collaborate and do the work?
A lot of it is them being able to collaborate and do the work, but along with that too, you want to make sure that we're not diminishing them, demeaning them, or disempowering them from what their cultural identity is, and their well-being. So with this piece of cultural safety, like we want to help empower them and be able to do that. And that helps with really bolstering that cultural safety piece. And if there's anything that we do as the provider that could affect them in a way where they feel powerless or they feel like they don't have a say in the opportunity of creating the treatment and the approach we want to take, then we start losing that traction of cultural safety that we're trying to achieve with them.
Okay, so with this study, you got some kind of rich data on sort of the perspectives on these 4 behavior analysts. What were some of the big lessons, outcomes of this study?
It was really exciting, actually, when I got the results and starting having that moment with my primary research question. What I ended up finding as far as, how do behavior analysts like practice using those components of this model as culturally responsive care, I found 3 major things that were pretty heavily rooted in all of my participants' responses and like being able to connect the themes that I found. The first one being the opportunity for the practitioner's humility. So when the practitioner realized or recognized that they were not the expert in that moment and they were able to create an atmosphere where they're learning from the child, the caregiver, the family, that actually helped in driving a lot of that collaboration piece when it came to treatment design, the treatment implementation. So like, how are we actually doing the goals and how are we actually working on these things? And cultivating that throughout the entire process, not just at the beginning. So this is something that is never ending. And I know that Dr. Wright talks a lot about this, where the process of cultural humility, there's not a start and end. There's no such thing as I have learned all the things that I need to learn and I am good. You need to continuously learn. Our world is constantly evolving. Our society is constantly evolving. The people in it are constantly changing. And those that we serve as clinicians also are too. And so when the practitioner really embraced practicing humility within their approach, that actually helped facilitate a lot of the cultural responsive care approach and implementation of things when they were interacting with their families. The next thing was building and maintaining trust. Within our clinical model, we emphasize with RBTs like, hey, pair and build rapport, and they do that really, really heavily when they're first getting to know a kiddo. But for clinicians who are trying to actually practice culturally responsive care, you have to do that in the very, very beginning and make it ongoing constantly. Because it relates back to that piece of if we are not maintaining and building trust continuously with the family, we lose that ability for them to feel culturally safe with us. And then that point, it can dissolve communication and it can impact their ability to continue with ABA treatment. And so building and maintaining trust by having that communication piece, spending time with the family, learning more about who they are, what they value, what they see for their child or adolescent or their loved one, and have that ongoing actually help throughout this entire process in what culture responsive care actually looked like. The last element of that, though, was also the practitioner's vulnerability. Vulnerability in the world of behavior analysis can be a really touchy subject because sometimes as I said earlier, we like to be right. We like to know what we know and really lean into that. But when we are in the position of creating patient-centered care, which is what cultural responsiveness is, we need to be vulnerable. We need to admit when we are wrong and being able to recognize, I don't know that. I need to learn more and I need to learn it from you.
Yes.
And we also want to recognize what our biases are. Our biases can be something that's overt or covert, so things that we can see that are things that we know about ourselves, or things that we don't necessarily like see, quote unquote, but we practice and our actions are a result of that. And so that's something that we need to recognize as well, is that the practitioner's vulnerability actually is a building block for building culturally responsive care and delivering that within ABA. So those are the three major themes that I found for behavior analysts when they're trying to practice those components of the access model with the autism population and their families. What was interesting with this too is that it actually relates back to quite a bit of research that has been done, but putting it together. So cultural humility has been talked about for several years now and is commonly used to talk about cultural responsiveness and so on. But it's just one path of what this actually is, right? And it's going to be an ongoing process. And we want it to be that ongoing process. The practitioner's vulnerability, we have to be really intentional in how we're creating dialogue and seeking feedback and guidance on what we're doing in our treatment design. I know for myself, many years ago, I didn't always ask the family for feedback on what I was doing and if it was working with their family. But that's something where we're trying to create that vulnerability of, hey, I'm helping you. I want to support you. I recognize these are the things that you need, and I've written these beautiful goals. Are these goals in line with you, or what can I do to help change this and help support the family, right? We're actually opening up that opportunity for collaboration, for that feedback to grow together with the family that we're serving. And so that piece comes into play as well. And then along with building and maintaining trust, many studies have talked about this, especially within the healthcare field, of we need that trust with our patients, our clients, in order to have ongoing care, ongoing dialogue, and also actually help the sustainability of the treatment. So one thing I found as I was doing research within my study was with many families who are culturally, ethnically, or linguistically diverse, if the ABA treatment wasn't designed in a way that was culturally inclusive of the family, they were more likely to discontinue treatment. And so this is something where we want to try and incorporate that, where we're building trust, we're building that collaboration for them to have sustainability of the treatment itself, for if and when time comes where we can start to reduce that treatment, or we're changing up our approach or our model, but it best serves the family no matter what. We're a part of it. So what I found within the study was that as a clinician, we are a part of the entire journey that the caregivers, the child, the adolescent, whoever is part of this journey with us, we are in it with them, and it needs these aspects of it. So with the two secondary questions that I had, which was interesting, was the first one was what are the actual assessment practices that behavior analysts use to create culturally valuable treatment or things that work on patients' lifestyles? So open-ended questions. So asking really, really broad questions in relatable language was something that came up pretty often. So we love jargon. We use it all the time, but sometimes we have to remember who we're talking to, which we're encouraged to do that by the board and in our own practice. But taking it a step further in asking very open-ended questions, which allows the family or the caregiver or even the individual that we're directly serving to share with us what their perspective is and how they can actually contribute to their treatment design. The next thing was active listening. So spending more time listening rather than speaking. Many times we're caught in the moment of, hey, they need help. I'm here. I'm ready to help. I want to do that. And we're very solution oriented. But when it comes to actually creating a culturally inclusive treatment plan that is heavily rooted in compassionate care, we need to be able to actively listen to what they're sharing with us and supporting them with that. And then the last thing was adapting treatment. So within the medical model, we write our set of goals and we have all of those pieces. Sometimes we rarely make changes to it because we have either multiple cases that we're working on, or we don't necessarily have the time to go back and see, does the wording of this need to be different and such. But one of the things that actually was very helpful is adapting the treatment as we get to know the family. So as you
Mm,
continue to build that relationship with them, building that rapport with them, and then understanding things, so you have that ability to recognize the cultural sensitivity to different aspects, and then that facilitates the cultural safety, you can incorporate that by adapting the treatment, refining it even more to be solely individualized for that family and for that recipient. And so those are three main practices that were found to really help build culturally responsive care and inclusion, and what it actually looked like, not just on the initial process of building treatment design and so on, but the actual implementation of it. So doing it too. And then the last question that I had was, what perceived barriers hindered me from being able to do this? And two things came up. One of them was insurance requirements and funding, which can be a touchy subject. And I've shared that my experience has been in the medical model pretty heavily over the years. And so this is something where with those insurance requirements, with funding, you're only given so much time to do assessment. And sometimes assessment is the only time that you're really spending time talking with the caregiver, family, or the participant. And that's where, because of those limitations, and it's like, well, I only have this amount of time. Sometimes you get locked into that time, but not recognizing I can do more. I can do more than this to continuously build that and practice all those components of the access model. And it can be limiting because everything is put to a time limit, but building relationships doesn't have a time limit. Building rapport and gaining trust and maintaining it doesn't have a time limit within our treatment model. When we're entering into those patient-provider relationships with these families and the caregivers, we have to also recognize that it's for the long haul, whatever that long haul might look like for them, and continuously doing that. Whether it's we have the billable time to do that or we don't, we still want to continue to do that. But it is something that has been seen as a barrier of wanting to be able to gather more information before they write a treatment plan, or being able to kind of build more collaboration. So for example, you have your 2 hours of assessment, and then you have like 8 hours, or sorry, like a remaining 6 hours to write your report. But you might actually need more time so that you can continuously be collaborating as you're writing the report with the family, and creating something that is going to be culturally congruent for them. The last thing was that was a barrier, was poorly established relationships. No, relationships are not on and off switch. And many times with our model of like, hey, I'm here to help, I have my cape on and I am ready to go. And we're trying to share with the family, this is what I can do, this is what I can offer you, this is how I can help. And you're starting that from the very beginning versus pulling it back a little bit and relating to the family first. Sometimes say hello, right? And so start that conversation and offering like open-ended questions, because poorly established relationships can make it very, very difficult to actually create something that's culturally responsive as a whole. Because the relationship can't be assumed from the very beginning. You have to assess and see that I have maintained this and I'm continuing to build it over time. And so those are some things that I found from this study, and it was quite a bit. It was a lot. For me as a practitioner, I had to take some time to reflect on it and realize like, okay, cultural responsiveness, culture responsive care is not black and white, nor should it ever be. And it's something that isn't something that we just do. And it, like, we do it, we say certain things, or we, practice it in a specific way. It starts with us as the practitioner to be able to build those relationships with families, recognize our own biases. So building that self-awareness, reflection, and practicing that ongoing with them and building that over time. So yes, it was very eye-opening. I'm really happy that I ended up having multiple questions like within my dissertation, because it really unfolded a lot of some of the things that were, especially as a field, are right there in our face, but sometimes we don't necessarily want to see it yet. But being able to see it for what it is and knowing, okay, this is where the work begins.
It's really cool. And then, so How has doing this study sort of changed the way you do work?
Oh goodness, a lot of what I incorporate. I recognize more often than not, I am listening to families. I'm listening to families a lot. I'm changing the way that I approach them instead of coming in really excited to say, oh, and your child's making progress on this and this, but really going in and checking in with them to say, how was this week for you? How was this day been for you? What is something that you're really excited about? And so finding those opportunities of asking those open-ended questions and giving them a chance to share what's going on. And then based off of how they respond, altering what I want to focus on with them. Or even if I had a plan going in, I have learned I need to change and adjust and be okay with that when it comes to how I'm approaching talking about ABA treatment and what it looks like for their family. When it comes to treatment plans, I have switched up a lot of what I do for those initial times of getting to know the family is I even share with them because sometimes there's a question of like, is there any barriers that we need to know? It's really broad. But I now will take a step further and say, what are the things that you value as a family? Are there things that are culturally, ethnically, linguistically valuable for you? How do you want us to incorporate that within treatment for your kiddo and supporting them?
Sure.
And so that's where I've changed up a lot in how I approach talking about it. I'm also very aware of when we need additional supports to help the family feel more comfortable. So for many families that are coming in, especially if they're unfamiliar with what behavior analysis is, let alone behavior analysis therapy for children who are diagnosed with ASD or individuals diagnosed with ASD, many of them just need to have a place to be relatable and just need to share all of their thoughts. And sometimes if there's like a linguistic piece that I don't have, I will tell them, let me know how I can help because I will make sure that we have all these pieces in place so that you feel comfortable sharing with us everything that you need for your loved one. And so it does take a lot of resources, right? And it does take a lot of planning and such, but those end up being the most meaningful and most impactful because they can fully understand and know what's going on within the treatment that they're signing up for, whether they're like a stakeholder or they're the individual that's receiving that treatment. Yeah, that's something that it's not very, cut and dry when it comes to that piece of things, but recognizing as a clinician, it is okay that we're adapting this and we're making talking about human behavior human again and what that looks like.
No, I love that. One last piece that in the study that I haven't seen in a lot of dissertations is this sort of fourth chapter with your executive summary and distribution of findings. I'm particularly interested in the latter, sort of the distribution of findings. You actually have a bit of a plan to sort of share this information. Can you talk a little bit about, well, A, why you included that piece, because I don't always see that, and B, how that's going?
Yes, that is definitely, it's part of our dissertation model that we had through the university.
Okay.
And I think it also, I will say when I was doing my research, I was a little nervous about this part of it because, they want to hold us true with what we're doing. And for me, as I shared with you earlier, I want to be able to be somebody who is helping support in this area, but also build and pay it forward. So this process has been interesting so far. I've been able to work with different stakeholders in some capacity. So for example, right now, I'm currently an adjunct professor, so I have the opportunity to work with my current graduate program coordinator and talking about what culture care looks like. And it's been great because I at least have been able to start small in talking about how do we have these conversations, how we have it in a space, especially within the university setting, having it in a space where students who are wanting to learn how to do this and do this in practice feel safe to do that. As I shared earlier, it's a lot of self-reflection. It's a lot of self-awareness, and you have to identify things that you are either confident in or things that might be a bias. And creating those spaces in the university setting I've noticed has been helpful for students to begin that conversation. They may not always outright share, this is something I hesitate on, or this is my bias, but they will share, this is something that I need to work on, and this is how I'm going to do that. And so facilitating those conversations have started within the graduate setting, and I've started to see how some graduate programs are altering their ethics courses specifically to incorporate this piece, because this is kind of the area of cultural responsiveness fits. I would like to see this also expand into like behavior change interventions and principles, and many times students are taking a separate course on that, and how they can actually create a truly culture responsive program or objective that's unique to the learner that they're working with. With the BACB, that was my big one. I have not yet done that yet, but I would like to one day. I don't know when that will be, but this is something I definitely want to hold myself accountable to, is just presenting on how we can create expectations, policies, even an education curriculum on what this would look like for either something that can help shape graduate programs or something that helps facilitate for currently practicing clinicians. And so that's something that I'm hoping to do. I haven't done it yet. But being able to share in that capacity. And then currently practicing BCBAs and BCBADs. I've done quite a few presentations for talking about my research over the last couple of years. And so I've started to do that. And I've had some really good conversations. I've also had some really tough conversations too. And it's been an interesting aspect of watching those who are very tried and true to the principles of ABA, and then those who are learning to adapt and change, and coming back to the concept of remembering, hey, we're living as humans, we engage in human behavior, and human behavior might look a little bit different. And so this is something that's definitely started. I've had some tough conversations when it comes to keeping things uniform and such. And one thing I share in my research is, for example, like our assessments are framed within the Western framework. And so Western behaviors. But there's not necessarily a lot of deviation that's in printed form that many of our clinicians are using as guiding practices for their treatment design. And that's something that we can work on. That's something that we can, assess and see, like using these as tools rather than using them as the end all be all for specific things that we need to be able to see. I've also had, conversations on, I love this work. I love the ethical practice of being able to do it, but I myself don't want to incorporate it because it's too hard. And even in our discussion today, we've talked about the different aspects. It's not something that you're going to jump right in and outwardly do. You have to start as a clinician yourself and begin that self-work of, I need to recognize these things. And then what I'm bringing to the table when I'm having those conversations with those in need, and then going from there. So this is something that I've started and working with, talking with currently practicing clinicians. And it's still ongoing. So I'm really thankful. I've had the opportunity to present at a couple of conferences. And earlier this year, I got a chance to present at APBA. So I'm really thankful for Dr. Sellers allowing me the opportunity to do that, because it's something that we can continue to talk about. And like, even for me, I actually appreciate the conversations for those who are having a tough time with it, because I will also want to learn more about their perspective and how we can incorporate that, because that's actually something it's not going to be them alone. There's many clinicians who are struggling with that as well. And it's okay. We just need to start having the conversations around it too. Especially since we are entering into those patient-provider relationships, and we don't want to be the barrier of success for that patient. And so what can that look like? And then my last stakeholder that I had was parent ASD patients and their caregivers. I haven't had an opportunity to do this just yet, but this is something that I've begun to brainstorm, because I want families and caregivers and autistic individuals to recognize that they have a say in their treatment. They have a
Yes.
say in providing feedback to their provider,
Third secret word is barriers.
Absolutely.
collaborating with them, asking to be a part of their treatment design, and remembering that the provider is there, but we want them to be the one who's walking beside them in their treatment to help them get from point A to point B, not leading them so far ahead. And so that's something that I'm hoping to do, as well as being able to have that opportunity to share that with families and caregivers, and also those individuals, just so that they remember that this treatment is not one-sided. It is completely immersive. It's completely comprehensive. This is what it looks like. You have an opportunity to be a part of the treatment model as well.
No, I love that, Ruby. I love the study. I love the work you're doing. And yeah, I think, I hope, this podcast will then be another way for folks to start learning more about kind of how to do this. What are kind of, besides sort of filling your commitments written in the dissertation, what are sort of, what's on the horizon for you and your work?
I think for me right now, I'm continuing to teach ethics. So I'm incorporating lots of cultural responsiveness for my graduate students right now.
Nice.
And also within my clinical work, incorporating this into practice. And so this is something I've had the very up close and personal opportunity to do while being in the San Antonio area. And it's something where I've started to develop a lot of training and mentorship on how we approach this at a small scale. And something that I want to continue to do within clinical work is we can help foster and create culture responsive clinicians, but also truly a very strong compassionate care approach that helps to improve the quality of life. And my hope is to be able to do a lot more clinical work and being able to foster environments, organizations that create an opportunity where clinicians are not just checking off that they practice ethically, but they are truly doing that in who they are and what they're bringing to every single family, every single individual that they're working with, and having that piece of them be as ethically responsible as a clinician. And we're continuing to practice what we do in a way that respects, that maintains, and is compassionate in our approach. And so my hope is to continue to have that aspect of, I really enjoy teaching my graduate students, but I also like to see the work firsthand and being able to create curriculums and design ways and like policies, expectations, or even ways to help start teaching these things at a more global organizational level as well. So nothing set in stone as far as like concrete, areas and such, but I want to be able to continue to foster that, be able to foster that piece of it, because I have learned throughout this journey, if I don't say something about this area in particular, we will go on and we might lose a family, we might lose trust, and we might not be given the opportunity to really drive the change that we're trying to help families see, but also give them the opportunity to be successful in all aspects for their loved ones, for themselves. And that's kind of, I want to help be able to drive that piece as well.
Great goals. Thanks for coming on the podcast, Ruby. This was cool.
Yes, thank you. I appreciate it. And I appreciate being able to talk about this area. This is a long, many years journey, passion for me, and it's still going. So I'm excited to see how it continues to grow and having other people talk.
Right on.
If you enjoyed this conversation, I encourage you to check out these episodes. Episode 138, Culturally Responsive Positive Behavioral Interventions and Supports for Black Students with Dr. Rachelle Campbell. Episode 136, From Bias to Balance, Anti-Racism and Behavior Analysis with Dr. Sonia Levy. My two-part conversation in episodes 102 and 103 on enhancing cultural responsiveness and behavioral service delivery for Latino families with Dr. Natalia Baires, Dr. Luisa Ganon, Dr. Mariela Castro-Hostetler, Dr. Sebastian Garcia-Zambrano, and Patricia Guerrero, and episode 63, Equity and Systems Change with Dr. Noor Syed.
If you enjoyed this episode, please consider leaving a review on Apple Podcasts, Spotify, or wherever you get your podcasts. And please follow us on Instagram at BehaviorSpeak.